I'm usually the one who gets the phone call for the interview with whatever media outlet whenever there's another report coming out demonstrating our challenges with maternal infant health. And I take every one of them because I want everybody to know how important this is to Mississippians. This is important to our decision makers, the governor, lieutenant governor, the speaker, legislators. It's very important to the Board of Health, and it's actually statutorily my first obligation as state health officer, as I am challenged in state law to work to improve the health outcomes of Mississippians. Number one is maternal infant mortality and statutes. So I take it seriously. Very happy that we have people literally from all over the state and many different types of stakeholders. So obstetricians and family medicine and pediatrics and neonatology, but also very proud that hospital leadership is at the table, and it came to the table pretty quickly, and that we have nurses and other hospital administrators that work with labor and delivery issues. We have emergency medicine representation. We have been engaging EMS leadership, so we really do have a nice comprehensive group today. Also really grateful that we had Medicaid leadership. Cindy Bradshaw, Executive Director for Medicaid. Wait, Cindy, that everybody gets it. Cindy and her team are here. We have managed care organizations for Medicaid here. We're grateful Drs. Hamilton and Mitchell are here representing MCOs. And Cindy is really proud that I don't have a Medicaid ask. So, but I'm proud that they're interested in what we're doing. We have Richard Roberson and Kent Nico here with hospital leadership. So just such a nice cross section, and I am very grateful. I want to introduce you. We have 4 members of the Board of Health here. 2 of them will come say hello, and then Dr. Waits is going to have a presentation for us. But Dr. Rick Carlton is Board of Health member from Oxford, Emergency Medicine. We have Dr. Pat Cheney, OBGYN from Amory. We have Dr. Luke Lampton, Family Medicine from Magnolia, Mississippi. Dr. Thad Waits to my left, cardiology from Hattiesburg. And many members from the health department working to get us here. If you're an employee of the health department, stand up real quick. I need to make sure you're here, so thank you. So today, the first thing I want to tell you, as it comes to the obstetrical system of care, the only thing in stone is that we must do this. Everything else is on the table. So you were invited here today, and you notice there was not a virtual option because everybody would take it. But you're here today because you have the opportunity to make a difference in improving maternal infant outcomes. What we will do, we're going to set the stage for you so that you understand where we are with the evidence is showing. And we'll have some opportunity for you to ask questions of our presenters. Then at the end, I'm going to try to wrap it up, tie it in a bow in terms of why a system of care and really what that would look like, and then where we need your help. So we were going to start in just a minute with Dr. Thad Waits, who will be representing the Mississippi Healthcare Alliance, talking about systems of care, our history of systems, how systems have impacted trauma, STEMI, and stroke outcomes, and then and they will be an important partner with us. So thank you for being here. Dr. Waits, come.
All right, so I am a cardiologist, as Dan had said, so I have kind of been here from the start of this process, especially with STEMI. I'm also on the Board of Health, as you just heard, and I'm on the Mississippi Healthcare Alliance. So the Mississippi Healthcare Alliance is what I really want to give you very much an overview of, because that's the starting point for how we have systems of care here in Mississippi. So we're number one. Harper Stone came up to me one day when I was the president for the chapter of this cardiology and said, we're number one, but in all the wrong ways, and we have to do something about it. And at that point, we were having a chapter meeting of the American College of Cardiology, and there were 5 hospitals that had tried to get together, all the major big hospitals of the state, in a collaborative type thing, but it just was not working out. So then Harper, as I said to the chapter of the American College of Cardiology, what can we do? We came together with those hospitals. It was all voluntary. Everybody who was traveling all over the state to come to Jackson for the meetings, we're all doing it voluntarily. And our goal, our mission was to improve the health status of Mississippians. The vision of the Mississippi Healthcare Alliance was to reduce stakeholders and align efforts that reduce morbidity, mortality, and cost, and all of these things. And we were able to get that done. In 2009 is when we first started. In 2010 is when we established the first STEMI system of care. We were with Mary Courier at the time at the health department, and she helped us get it started on this and got a system of care adopted by the Mississippi State Department of Health. In 2013, with the template of what we've done with STEMI, and by the way, for those who don't know, STEMI is the bad kind of heart attack, the ST elevation myocardial infarction, but pretty well every medical person calls it STEMI now. So with the template of what we did with our STEMI system of care, we then were able to start our stroke system of care, again, combined with the Mississippi State Department of Health. And then jumping all the way forward to now in 2025, we're much more than just systems of care. We're dealing with emergency medical systems. We've established STEMI receiving hospitals, there are stroke hospitals. We have a commitment to educate health personnel from all over the state and the community. And we do a lot with registries, as I'll be saying off and on through several slides here. And we have partnerships with societies like the American Heart Association and the American College of Cardiology, and furthermore with some companies, for example, called Sarah, which is a kind of a smartphone, but it does a lot more than that. With that, and especially in OB and with maternal care and so forth, it may be a wonderful way to keep up with where your patients are and where they're traveling. Just having a little bracelet on the Pulsera will give you complete information of what's going on with that particular patient. We've been lucky in Mississippi to be in a fairly small state. Geographically, we have some things going for us. And because we're a small state, we really do network so very well. And the way we set up the STEMI system and then the stroke system also was we divided the state into 3 zones. So we have coordinators for each one of the zones. But Highway 82 and Highway 84 divides the state very easily into the north, the central, and the southern districts. And each one of those have their own coordinator. That's just part of how we do our committees and everything else. And we're also very lucky that, again, we're small, and if you took every PCI center and drew a 60-mile radius around it, then we cover basically the whole state. We have Vaden and Winona, a little bit of a problem in the middle, but they have Highway 95 right there to help them get down to whatever hospital they need to go to. But most all of the state is covered by a 60-mile radius. So when we had first the trauma system, which was by statute, the legislature did that. And then we developed the STEMI system and the stroke system. At that point, we were the only state in the nation that had 3 systems of care. I think we still are. I haven't kept up with the others, but like North Carolina was our template for how we got started, but they didn't cover the whole state. There were multiple counties that weren't included. But for here in Mississippi, the entire state was included in each one of our systems of care. We greatly depend on data, and here's a slide that I am so proud of and have been talking about for a number of years now. When we got started, we had the highest in-hospital mortality for STEMI. So you can see that number on the left, that's the Mississippi average is 6.8. The national average at that time was 5.8. Jump forward just 3 years, and we had lapped the nation, and we're down to 5.6 on mortality, while theirs had gone up. Now, we didn't maintain that through the pandemic. That really, with the EMS system problems and so forth, we're still struggling with that particular thing. And also during that time, a program called Door to Balloon, or D2B, was beginning to go on in all of the nation, where there were systems, but not necessarily statewide systems, in many of the states around. So the Mississippi Healthcare Alliance is what has done all of this, and with collaboration, of course, very much with the Mississippi State Department of Health. So many of the things that we have to do with this include guidelines and criteria. Funding is very example, and we're super lucky to have the best lobbyist around in Dr. Edney. He's phenomenal at what he can do with the legislature, and we've been so blessed to have his work. Partnership with the state health department is really what has been very critical of this, and will be going forward. So I mentioned data collection, the importance of data collection. We have systems of care gathered from national registries. And ours, we do a registry from the College of Cardiology called the National Cardiovascular Disease Registry. And we also have, within that, also a registry from the American Heart Association. It takes some process improvement. You have to continue to build on the process. And what we do is quarterly we have meetings, and right before the quarterly meetings we also have performance improvement committees that meet together. During things like this, we review the outliers, and with the outliers we assess their processes. We look at their standards to see what their documentation is. Look at all of the slides, like I was showing you on the mortality. We look at whether the abstractors are having a problem. And mostly we look at the top performers and see what we can learn from the top performers. So all the major hospitals in the state are bought in on this, and it's all blinded. It's all behind the performance improvement laws that we have in the state of Mississippi, that it's all private information for us to work with. Again, on funding, well, let's get past, but this is the last slide. These are the systems that the systems of care have to have, and Pat, this is what I was telling you. So you have to have standardized treatment and transfer guidelines. You need to have performance improvement and advisory committees. The designation is whether it's going to be a sending hospital, a receiving hospital, or you may, with OB, come up with different categories for what your hospitals will be. The process improvement part of it is so important with the PI committee. The data collection with registries is a huge part of it all. With every registry, every time we look at the data that we have, we're looking at things like first medical contact and when they arrive at the hospital, when the first EKG is done, just all kind of data like that. And it's going to be so important to you. And Pulsera, by the way, may be very helpful in getting all of that done. And then the rules and regulations that come from the health department, and finally the funding. And you need a Dan Edney around to make sure we have the right funding. So thank you so much for your attention, and I look forward to our further discussion.
What we're going to do is set the stage for you. Appreciate Dr. Wade's giving you the history and the success of our current 3 systems of care, and this new system will just follow suit. And so the things that are applying to the other systems will apply to this one, with a lot of data and performance improvement as a component of that. But there will be unique things, obviously, in the maternal and infant space that will need to be different, and that's where you will come in. Our next 2 speakers are going to show you the problem. One of the duties and obligations of the Department of Health is for us to administer the mortality review work, specifically with maternal death and then also child death. And I have the chair of those two respective committees here to present the data from those committees and to talk broadly in terms of the recommendations. And I want to highlight their important work. You need to understand these are subject matter experts who are volunteering to review deaths that are really hard to review. And they do it faithfully, and many have done it for a long time. And Dr. Tucker, I know, is involved, and there may be other members of our committees here, and I thank you for that. But what I want you to do is just listen to the evidence of what it is that we need to make better. We do have two types of data. We have our provisional vital records data with maternal death and with infant death. And so that is closer to real time for us. That's going to lag about a year behind. And we do as much as we can with the provisional data to make it as clean as we can as we use it. But the mortality review data is where the real information comes from. It takes longer to do that. That's going to lag a couple of years behind. But they're doing an awful lot of work, reviewing charts, talking to families, interviewing those who were involved. And it's very hard work, for which I'm very grateful, because it gives us an extremely large amount of very important information, not just data, but information. And then that helps us draft policy. And then after that, this will set the stage of why a system of care. So next I have Dr. Randy Henderson, neonatologist from Hattiesburg, who is the chair of the Child Death Review Panel.
So I'm going to talk about the system we have now. We don't really have a perinatal system, but I'm just going to describe kind of how it works as it is. And I'm a neonatologist. I work at Forest General Hospital in Hattiesburg, and I also work at Gulfport Memorial for Kinnico. And I volunteer as chairman of the Child Death Review Panel. The Child Death Review Panel is a really extraordinary group of people. We have first responders, we have firemen, we have policemen, we have an Attorney General's office, we have Child Protective Services, we have volunteer physicians. And what we do is we meet quarterly and we go through the deaths of children. And we dig into the cases, and we use all the information we can gather to try to come up with suggestions that might make things better. And we compile a report that then goes to Dr. Edney and the rest of the health department team, and then they present that to the legislature to see if they can make a difference. And there are many members of the team here today, and it's really an honor to work with these guys. So an offshoot of the Child Death Review Panel is neonatal death review. It's something we're doing this year, and I think the value of data is this: what gets measured gets managed, and that's what we hope to do. We hope to measure what we're doing, see if we can improve it. So infant mortality has really improved in Mississippi over the years dramatically. 1917 was the first year we kept track of it, and at that time, believe it or not, it was 99.3 per thousand. A very high rate of infant mortality. And we've improved it. In 2022, it was down to 9.2 per 1,000, and the national average was 5.61. So that's a great improvement over a period of time, but it still leads the country. We're still the worst in the nation when it comes to infant mortality. Neonatal mortality is death in the first 28 days. In Mississippi, our neonatal mortality rate was 5.4 per 1,000 with a national rate of 3.6. That was 186 neonatal deaths, and that's about 58% of the infant mortality in Mississippi. Remember, neonatal mortality is a fraction of infant mortality. This is wonderful data put together by the health department. Really, our neonatal mortality has been flat for a number of years. If you look in this next chart, you can see in 2012, our infant mortality was 8.9. In 2023, it was 8.9. You If you look at neonatal mortality in 2012, it was 5.5. If you look in 2023, it's 5.2. So even though our birth rate is dropping, we've kept that same proportion, whereas the rest of the country has managed to reduce neonatal mortality steadily. If you look in 2012, it was 4 per thousand, and in 2022, it's down to 3.6. And if you look at our numbers, they just continue to hover. We've not made the dent we wanted to make over time. This just shows you our birth rate declining. It really peaked in 1955 at 62,244, but you can see in 1985 it was 43,432, and it's just steadily declined, most recently 2023 at 34,354. So I want to talk about what's promising in Mississippi first. I think we do have some good things going on in terms of our perinatal system, things that could help. I think telehealth for prenatal care is really a good thing. We probably need more of that. I think there is some outreach education going on that's supported by UMC, the STORC system in particular. They have teams going to hospitals and they're teaching about emergency OB care and emergency neonatal care. There are, at least in my experience, and you have to understand, I've been here 29 years, so there are more hospitals that have 24/7 OB care than when I came. We have more perinatologists than we did when I got here. We do have nurse midwives, particularly at UMC. I'm impressed about the role they're playing in reducing the incidence of C-section. But the two biggest things that I think will make a difference in infant mortality and neonatal mortality are presumptive eligibility for our Medicaid moms, who represent 57% of our deliveries, and extended postpartum care so we can take care of those women between those deliveries. I think if those two are taken advantage of, they can have a really great long-term effect. But we do have uncertainties. We have problems in Mississippi. We have counties with no delivery service, 51.2% according to the March of Dimes most recent report. We have 38 hospitals that offer a delivery service right now. There is uncertainty about where we can get prenatal care in Mississippi. Now, just recently, I know that Dr. Dobbs and the Evers-Williams Institute came out with a list of prenatal care and put it on the website. And I think that's tremendous, but that really needs to be a living document that we constantly update. We have 4 neonatal transport teams for the state of Mississippi, and all of them have their own problems and probably could be better coordinated. We do have something new, which may be the future, but there's uncertainty about it still. We have telemedicine for acute care of newborns with nurse practitioners backed up by physicians as needed. One uncertainty that I've had a lot of recent experience with is home births with midwives. And the number of home births has increased 56% between 2016 and 2022. It's increased in Mississippi as well, not quite as much. There were 290 home births in 2023. I'm on the Genetics Advisory Committee, and we look at the newborn screening, and we had 14 midwives who were screening their babies and sending in samples, which is a good development. We want to get them into the system if they're going to be taking care of the births. Right now, though, there is no regulation of the midwives, and there are many different types of midwives out there delivering, and I'm hopeful that we will reach some understanding in that area. Other problems, well, we have multiple ambulance systems, and I'm not an expert in this, and we do have people in here who probably are, but I don't know how coordinated that system is about, in terms of where mothers end up. I do know there's limited training of ambulance EMTs about newborn stabilization, particularly the use of laryngeal mask airways to intubate a baby that maybe they can't get a tube in, or chemical mattresses to make sure they don't freeze. This is true in all of our hospitals, that we have a high turnover rate of nurses that once we get them trained and they seem to be on a move, and we really have to keep that education going constantly. We also have a kind of a generational change. A lot of the pediatricians I trained with are very used to doing newborn care, stabilizing a sick newborn and shipping it out. But that generation is retiring in the next 5 to 10 years, and the younger pediatricians are not so crazy about doing that same stuff in the middle of the night. Other problems, yes. Other problems in perinatal care, we have a lot of care, at least of babies happening outside the state. We have babies from Mississippi that end up in Memphis, Birmingham, Mobile, and New Orleans. And they do a great job, but there's not really coordination in how we're handling all these things. This is just a list of the many different ambulance services by county. Some of these are big outfits. Some of these are mom and pop outfits, literally, where they just have 2 or 3 people running it. This is a great study by Sam Miller, who works at the health department. Basically, he was talking about how long a mom has to drive to get to a place where she can have a baby. And he crunched the numbers, and he found that basically there are 2 places. One region would be the Delta, and in the Delta you have to drive about 54 minutes, about 40 minutes to go 27 miles to find a place to deliver. And in Health District 6, it's 54 minutes to get about 38 miles. This drawing of the state shows you the dark blue is where it takes the longest to get to a place where you can have a baby. And this just shows you in the pink the places where there is delivery service, and then it's, as you get further out, the color is more blue. And if you look at the middle part of the state there, there's just not a lot to offer. So if you live in that part of the state, you have quite a distance to drive before you can get a place to deliver. This shows the Delta specifically, and Greenwood is on this particular slide, but it's no longer there. So that area is even more blue than it was before. So we have long drive times in Mississippi. Major portions of the state are not within 60 minutes of a birthing facility. Of the Delta, it's about 40 minutes. Health District 6, about 54 minutes. Now, why is that important and why does that matter? Because that overlaps with the areas of the state where the infant mortality is the highest. I don't have a slide for neonatal mortality, but remember I told you at the beginning that 58% of infant mortality is neonatal mortality. So it's not a coincidence that we have the highest infant mortality where we have less access. And we have the lowest infant mortality down there on the coast where we have a lot of access between New Orleans, Mobile, and Gulfport Memorial. My personal experience, I think that there are just little things we can do to make things better. I know when I was on call, I had to run up to Garden Park. There was a mother who came to deliver her preemie at Memorial, could not find a parking space. So she drove on up to Garden Park where she could find a parking space and delivered in that ER. Now, Memorial's made a change. We now have valet service, so that would not happen again. But I'm just thinking things like that. In experience, my experience, I've had to go to hospitals around the state to help stabilize a newborn. And we have mothers who are getting perinatology care in New Orleans and Mobile and then trying to rush over there to deliver, and they don't quite make it. And they kind of drop into our hospital and deliver. Maternal transports. What I did is I called a company called Definitive Healthcare, and I said, can you tell me how many maternal transports we do in Mississippi as a state? And what she did is she cross-matched the CPT code 59400 with the number of ambulance transfers, and she came up with this number 1,181. It's just a ballpark number. I mean, it includes or transfers before and after delivery, but it's just a place to begin. I asked the obstetricians at Forest General about how many maternal transports do you get, and they get about 8 a month, so 96 a year. And then Dr. Tucker was kind enough to do some of the same research at UMC, and he found about 52 transports a month, or 624. I'm sorry, it should be 624. So, that's about 724 maternal transports there. I don't know the numbers for North Mississippi, but I imagine they'd be high. So why would it be important to collect this data? Well, this is a study done at Johns Hopkins within their maternal transport system, and what they found is that 48% of their mothers delivered at the receiving hospital, 66% of the deliveries resulted in an ICU admission, And 18% of those transports could have been prevented with better planning for that particular mother where she was going to deliver. Other states have policies for both mothers and neonatal transports. I just have questions that many of you may know the answer to, but I don't in terms of Mississippi. When does a transport happen between a level 1 or a level 2 to a level 3 or 4? And my simple understanding of the difference is at a level 3 and 4, you have a OB and an anesthesiologist physically present 24/7. That makes it a level 3 or above. The other hospitals, you do not. You just have someone to do the delivery that's readily available. Then just questions like my own labor and delivery nurses weren't quite sure to the answer to this. So when is it possible to transfer a mother? If she's at 4 centimeters and in labor, would you not transfer her? Or does it depend on the doctor? Does it depend on the gestational age? Does it depend on the team that's going to do the transfer? These are just the levels of care. If I had to say right now, I would say we have one level 4, just UMC. And the difference is they have ICU capacity for mothers, and they have maternal fetal care whenever they need that. Level 3 would be like Forest General, where we have OBs and anesthesiologists available 24/7, and we have maternal fetal care when we need it. We're not alone. There are other states like South Dakota where over half the counties don't have any maternal care. 9% of South Dakota mothers have to drive over an hour to get to a place to deliver. 10% of their infants are admitted to the NICU. They only have 3 NICUs in the whole state, and their birth rate is 11,200. An OB there, Dr. Booner, says that it's the dark of night right now, but at some point there will be a dawn or a movement and a realization that this isn't working and that we need to change. That's kind of where we are. And I think the Arkansas also is in our boat. They have the nation's highest maternal mortality rate and the 3rd highest infant mortality rate. And this is by Alan Nichols, the CEO of Mainline Health Systems. He says, everybody has a great plan and none of it is coordinated. We're in a state with very little resources and we're going to waste a lot of them. So my recommendations to end, just to make better use of what we have in terms of data collection, education efforts, and services. We do need a living document that keeps track of prenatal services and providers. We need to coordinate maternal and neonatal transports within the state, and we especially need to track maternal transport data at each hospital so we can sit down, analyze it, see what went right, what went wrong, and then try to match mothers' delivery to the best place. Do y'all have any questions? I appreciate being corrected on anything I said that doesn't really match what some of the experts out there know about the systems. Yes, sir. So you're asking basically the causes of low birth weight? Yeah. Well, we have the highest prematurity rate in the nation, 15%. We have a patient population where over a third have diabetes. We have hypertension, which is 30% of the population. And then we have, unfortunately, these maternity care deserts where moms just can't get regular care. So these are things that I think will be addressed with the presumptive eligibility, with the expanded postpartum care, which I think are very valuable. But I know a lot of other people in this room know solutions or suggestions anyway to address some of these problems. Yeah.
More OBs in our state. We won't graduate 6 a year from UMC.
More OBs. Dr. Tucker,
Half of those go out of state.
Exactly, or subspecialists. So we only have 6 OBs graduating from UMC a year.
Yeah. Dr. Tucker, can we do more than 6?
Right now, no. We do have some other things working. It's not going to double it.
Yeah. Yeah.
And that's out of your hands anyway. That's with graduate medical education system that makes those decisions, right?
We, as many of the obese in the room know, we have for 50 years, Tupelo, over 30 in Hattiesburg, formed our residents out to those areas. So, we're struggling to keep up with clinical exposure that our residents need. So, as you pointed out, our birth rate is down, and just the state of Mississippi as far as training more obstetricians
Dr. Tibbs.
So with the resistance to the HPV vaccine around here, have you noticed a difference since we started giving it in terms of suspected cervical cancer and the incompetent cervixes and cerclage and all of that? Has anyone looked at that study to see if that's contributing?
That sounds like a Dr. Tucker question too. I don't have.
I didn't get the question, sorry.
Oh, with the HPV vaccine, has there been a reduction in the problems with incompetent cervix,
Yes.
things of those nature?
My knowledge, no.
Yeah, Dr. Waits.
You showed that there's a lot more, the rate of increase on at-home births is really great around the nation, but not so much here. What's the reason for that? Is it more midwifery around the nation than it used to be?
There is, and ACOG actually includes in their level 1 description that one of the professionals that can be there for delivery is a midwife, a nurse midwife.
And they're increasing all over the nation other than here?
That is my understanding.
Okay.
That is my understanding. But I think here the goal will be to make them part of the team, as opposed to have independent. Yeah.
There you have the evidence of child death review and an expert in the field of neonatology. I do want to let everybody know that we are recording today, so if you have to leave early, you'll miss the best speaker. But more importantly, we have for you a recording, and if you have team members back home, we have requests to record, so folks back home could participate, and we'll be happy to provide that and the slides for you. I do hope you see and you paid attention to the gaps that Dr. Henderson pointed out, and I prepped you not at all in your presentation. I influenced his presentation not at all, which is how we do our mortality review work. They work independently, and we take what they give us and then generate the reports. But I want you to pay attention how the system of care will satisfy some of the challenges that Dr. Henderson and our colleagues in neonatology, pediatrics, and family medicine are seeing. Next, I'd like to invite forward Dr. Michelle Owens, who is chair of our maternal mortality review committee. And Dr. Owens is a specialist in maternal fetal medicine and very grateful for her service on the NMRC.
Together. For disclosures, I participate on 2 scientific advisory boards. These are related to novel technologies related to preeclampsia, so it doesn't have anything to do with this conversation. And I'm also the perinatal medical director for Magnolia Health Plan, so that's another disclosure that was not included. You guys who've ever heard me talk, you know how it starts. They're getting bigger, in case you haven't noticed. So these are my 3 children. And this particular conversation, as a person who came to Mississippi and who has had the opportunity to birth all of my children in Mississippi, to be a Black mother in Mississippi, and to know the challenges that are faced by women who are birthing in Mississippi in general, and specifically for those in communities of color. So this is actually my success story. And as I see them grow every day, I am reminded of the amazing things that women's bodies are able to do, the joy of motherhood, and how it commits me every day to make sure that I try to perpetuate that and create those opportunities for as many women as possible. And I know that many of you in this room, in your own respective ways, have also contributed or contribute on a regular basis to that very same thing. So really quickly, I don't know if we need this, but because I followed Dr. Henderson, note to self, I won't do that again. But maternity care deserts, again, places where there's no obstetrical care available. When we're talking about preterm birth, we're talking about 40 weeks is normal gestation. If we're talking about a preterm birth, it's a birth that occurs prior to 37 weeks gestation. When we use the term low birth weight, typically low birth weight is less than 5.5 pounds. If you're born at term, very low birth weight, less than 3.5 pounds. And then social determinants of health. I got a lot of public health people here, but you know that just basically all of the different things that contribute to who we are, how we live, breathe, learn, and exist, and how those things actually influence not only who we are, but how we engage and experience healthcare. So I'll start this with a fundamental belief that I have. I believe that you should not have to choose between living and your health. I believe that you should be able to live healthy. And I think that many of you in this room have committed a lot of your careers to trying to problem solve on how we can do that for people in Mississippi. But this is a fundamental belief for me, and it guides the work that I do and is also going to be present, I think, as we talk about some of these issues. So we'll start by talking about babies because, as you heard, I'm a maternal fetal medicine subspecialist, so I get the pleasure of having two women. I get to take care of mamas and babies, although I'm kind of like a quarterback because once the baby's out, I kind of hand it off and let the pediatricians and the folks on the other side of the placenta take care of the rest. But we'll talk a little bit about what's going on in Mississippi with respect to pediatric care for the things that Dr. Henderson hasn't already mentioned. I don't want to be redundant, but we do have a high prematurity rate. We do have a high low birth weight. Our infant mortality rate is still high in the nation. Our cesarean section rate is actually high in the state of Mississippi. And when we look at our overall uninsured population, roughly 1 in 6 women of childbearing age are uninsured. So if you talk to the March of Dimes, they don't exactly give us great grades. I think we had a D once, but consistently, for roughly the past 20 years at least, we have been given Fs. We got a D once, and we won an award that year because we actually had made some substantial changes. But our overall birth rate of 15% is higher than the national average, which is roughly 10.4. And when we look at that, there are also disparities that exist. And we see that African Americans are disproportionately affected with higher rates of preterm birth, higher rates of infant mortality, higher rates of maternal mortality. So that's going to kind of be a common theme. And I will also add that one of the unique things about Mississippi that you may not know is that we actually have per capita one of the highest population densities of African Americans. And so when we talk about these, it's of specific interest in this state because our numbers are higher than a lot of other populations. And then when we look at the overall report card, so they don't say great things about the country in general either. So the overall is a D+ rating for the United States. Oh, moving a little too fast. And so this is just another schematic that kind of shows, since we got people from all over the state, you might not have started out in this state. And so some people like to look and see where their other homes may be, but to see how we fare nationally. And the scores across the bottom are also designated by color, and you can see A being the purple, all the way down to F, which is in red. We tend to kind of concentrate our redness in this area of the Southeast in a variety of different ways when we're talking about health outcomes. And then when we look at preterm birth rate, as I mentioned, healthcare disparities do exist, and this just kind of stratifies by race and including ethnicity, what the numbers look like when you compare per 100 births by maternal race and ethnicity. And you can see our African American population with the highest, and also the American Indian and Alaska Natives with the second highest rates. And I think that's also important because a lot of times when we have these conversations, we don't remember to include our American Indian brothers and sisters, and their outcomes are oftentimes on the higher end of the disparities. So now we'll get to move on to the mom's part. So first, for those of you who don't know or who are not familiar with what the Maternal Mortality Review Committee is, I thought I'd give you a brief overview. With House Bill 494, you will not be tested on that, which was in 2017. The MMRC was established. The purpose of that was really to, as you see here, foster reduction of maternal mortality and morbidity in our state, and not just to reduce, but to also improve. So there are two things that we were focusing on: improving health status of pregnant women and postpartum women. So what do? We are a multidisciplinary, independent team, And when I say multidisciplinary, let me be very clear, we are not just a team of clinicians. We are made up of community partners, stakeholders from a variety of different areas. There are also public members and other individuals who may not have a clinical correlation or a clinical connection to the work, but who may have a personal investment in the work. And so we get together, we review maternal deaths. I also heard that I got hospital people here. Hi, hospital people. We love you very much, and we thank you in advance for your rapid response to our request for records when we have these maternal deaths. I will share with you that information is really helpful. How many clinicians do I have in the room? Clinical people, raise your hand real quickly. Thank you very much. Okay, how many clinical people have ever been frustrated because you have had to take care of a patient or you have a patient in front of you and they've been seen by somebody and you have no idea other than what they are either telling you or can't tell you about what happened? Same number of hands almost. So one of the beauties of the work that we get to do at the MMRC is we have the opportunity to see the information over a continuum. So we can have access to prenatal care records, we have access to hospital records. Guess what? If she went to 4 different emergency departments, sometimes we'll have all that information. I know, right? Sounds great. Sometimes. This information actually is not punitive. The work that we do is not punitive. We do not participate in medical malpractice claims or any of those things. This information is quality improvement, and so that we can try to get an accurate account of this person's life as they navigated through the healthcare system preceding their death, to try to see what opportunities exist for us to be able to close those gaps and to make things better so that those deaths that we deem to be preventable don't happen again. So what do? We are asked to determine, number one, what the cause of death is. We get death certificate information, we use vital statistic information, we use birth certificate information. If you're a person who gets to sign off on those things, making sure that they are accurate is also very helpful. We determine pregnancy relatedness. So is the death pregnancy related? Was it something that was exacerbated, caused by, or made worse by pregnancy? Or was it just pregnancy associated, something that happened in close proximity to pregnancy but was not related to or was not directly influenced by pregnancy at all? We get a chance to talk about preventability. Was there an opportunity to change the outcome? And if so, how great was the opportunity for us to do that? And then also, are there other contributing factors? Again, the more information we have, the greater the likelihood that we have an opportunity to get a holistic view of this person's life and to be able to capture the social determinants of health and other factors that influence the person's outcome and potentially their death. And then we get to make recommendations. And that's where the rubber meets the road. Not only what have we learned, what have we been able to determine our opportunities, but how are we going to fix it? And the nice thing here is it's kind of like we're writing with a blank check. Because we are an independent committee, we have the opportunity just to say what we want to. We're not partisan. While we are established in statute, we are not subject to the will of any particular entity or body. And so we get to put our heads together, a lot of different people from a lot of different walks of life with a lot of different lived experiences, and to be able to try to figure out what are the ways that we can really truly make impactful change to influence the lives of those women who are still here. How can we keep a death that might be preventable from happening again? And then, of course, we report our findings to the CDC, where that information is aggregated and then produced by the CDC across the country. So we get to see how we fare nationally and also to share information. So now we'll talk a little bit about our statistics in Mississippi. So our maternal mortality ratio, which sometimes is referred to as our rate, the reason that it's called a ratio is really because it's out of 100,000 births. And as you saw, Dr. Henderson showed you that we don't have 100,000 births a year in Mississippi. So when you see these data, I think it's important to remember that we may say that it's 39.1 per 100,000, but in Mississippi at any given point in time, we may have 35 or 40,000 births. We used to watch the delivery data every year when I was working at the U, and when I was at UMC, we used to have 45,000 deliveries on a really good year. But typically that number has been less, and it's as you heard, decreasing. The non-Hispanic Black rate was 4 times higher than that for non-Hispanic white. So as I said, the disparities matter. They do exist, but they matter more in our particular population because of the density issue that we have. 57.5% of those deaths actually occurred within the first 60 days after birth. And so we talk about this because as we were having conversations about extending Medicaid coverage postpartum, well, are we really going to capture, is there an opportunity to capture a significant number? Well, this next statistic helps you to understand that. I'm sorry, when I move this, it gets a little wild for the pointer. 42.5% of deaths actually occur after that 60-day postpartum time. So from 60 days all the way through to a year after death, after birth. 83% were determined to be preventable. I think the lowest number that our committee has ever found has been around 80%. So between 80 and 83%, and I will share too that is also on par with the national average. Those numbers nationally are around 80% as well. And when we talk about what's preventable, it's whether or not the committees have found that there's any possible way that a change in events or if things have been done differently that you would have had an opportunity to change the outcome. So this is the national maternal mortality information, just to see how I've given you our numbers, but it shows you also how we fare in the greater scheme of the country. And I also want to mention to you, if you notice here, we talk a lot about the higher rates in African Americans, but the highest rate overall is going to be in this first column, which is our American Indian and Alaska Native. Top 4 leading causes, and this is from our Mississippi Mortality Review Committee report. When we look at what are the problems, we talk about our chronic health issues and the condition of the mothers when they become pregnant. But these are the things that we are seeing that are contributing most greatly to our maternal mortality. In the Black non-Hispanic population, overwhelmingly is cardiac disease and hypertensive disorders. Because this covered a 5-year epoch that included COVID-19, you'll see that it starred in everybody's show as one of the headliners, both for Blacks and whites. But when we take away COVID-19, then you see that there is a distinction, and what we're seeing is primary contributing causes of mortality between our Blacks and white maternal deaths. So cardiovascular related is still significant, but we see thromboembolic disease or blood clots and sepsis contributing more, or making a greater contribution in our white patient population. So I wanted to throw this slide in here because the work that we do is not going to be related to just one thing. And I hope that by putting this wheel here, there's something that you will see in one of these colors that somehow relates to a passion that you have, the work that you do, or a role that you play, a position that you have. And it's part of the reason why you are in this room today. Because the truth is that all of our patients, all of these things that we see are kind of the sum of all of these parts. And we are all being asked to do our part to try to help improve access. And when we talk about healthcare access, we know that it's more than just being in close proximity to a physician. It's more than how far you have to drive. It's about cost of care. It's about comfort with the individuals who are providing that care. There's so many different factors that influence a person's ability to actually have true, good maternal care access. And so hopefully as you're looking around this wheel, you can see a color that corresponds to you, or maybe you are multiple colors. Maybe you're part of your rainbow. But I just think this is a really good demonstrative of all of the different things that play an important role in healthcare access. Really quickly, the Maternal Vulnerability Index is something else that we've used, and it's really nice because what it does is it actually calculates based on a composite score how vulnerable a person is with respect to having an adverse or a negative health outcome. And so just as a spoiler, we're in a high vulnerability place, and that same red preterm birth area in the Southeast is also equally as Tiffany blue teal with maternal vulnerability as well. But it's just something to let you know that there are lots of different ways that we assess the vulnerability of the patients that we serve. You've heard a lot about maternal care deserts. That would be one of the problems that we'll have to solve. Of course, over half of our counties in Mississippi are considered maternal health care deserts, and that will be part of the challenge that we'll have to meet today. When we look at women who have birthing hospitals within 30 minutes, ours is around 25% in Mississippi, when the national average is just around 10. However, when you look at the number of births that occurred in these maternal care deserts, roughly 25% of them, and just over a third of babies born to women actually live in rural counties. So it's not an unsubstantial number. And when you look at where our providers are, 25% of all of our maternity care providers actually practice in what we call rural counties. So this is just another schematic that speaks to the time that it takes to receive or access care just from a distance or geographic perspective. I'm a little bit fast. And then here, when we look nationally, the big purple areas are areas that have longer travel times. So this is going back to the issue of how far a person has to go. And we need to start thinking, I think, about how we can help to expedite their process and get them on the road sooner. And the other part is, how do we bridge those gaps? And what are the opportunities to be able to decrease the distance between a woman and the care that she needs? This is my shameless maternal fetal medicine plug, where I just throw this up so that people understand all of the complexities of pre-pregnancy, pregnancy, and post-pregnancy care, and how those things all come together to contribute not only to issues related to prematurity, whether it be iatrogenic or because of maternal complications, how it also contributes to maternal morbidity and mortality, and how it's not just one thing, but there are multiple things that kind of play into this. It's still, in this form, somewhat of an oversimplification, but I think it is really helpful to kind of illustrate how all of these things are important. So I'm getting close to closing. This was a friend of mine, Joya Career Perry, who said, what would it look like for mothers to not only survive pregnancy, but to thrive? Let me be very clear. I love my work on the Maternal Mortality Review Committee, but death is the floor, it is not the ceiling. And when I get this starting at the thing that's the most significant and working our way back, but it's through the deep dives into the deaths and the hard parts that will really bring us into the brightness of women in Mississippi being able to thrive. And that's the thing that I hope that we will be able to accomplish together. So this is my wacky family. This is kind of how we function. For those of you who are noticing, this guy on the end, he just turned 14 and he's already taller than me. Yeah, so that's the thing. This is my gratitude slide. I am grateful for my care team who cared for me when I had these little people who are not little people anymore. My care team saved my life. I'm a survivor, I'm a near miss from a severe maternal morbidity. I am grateful for this opportunity to stand before you and to continue to participate in this work. And I'm grateful for each of you and the work that you do. Pregnancy shouldn't be a death sentence, and the work that we're gonna do is gonna help make sure that that is true. So thank you. Right, so for those of you who didn't hear, the question was related to the identification of engagement as one of the problems. And what I will say, and I know we've got some folks from the Division of Medicaid and some other managed care organization representation here, and we got clinicians. So you can't make grown people do anything. You can't. But I think it's kind of, in my mind, I see it more like a field of dreams, right? So I think if you build it, they will come, right? And I think that, so trust number one is not gonna be built by any system. Trust is gonna be built by when a person engages in how they're treated and how they're felt, how they feel during that interpersonal period. The other part, though, is gonna be, how do we remove barriers to make it easier for patients to engage? If we have the ability to remove the barriers, then I feel like you're trying to meet the people where they are. It does not mean that we're gonna be 100% successful and we're gonna eradicate all maternal mortality, or that everybody's gonna come. There are gonna be some people who may not still be engaged. We may not have 100% engagement. But what if we make it so that on our end, from our perspectives, we have tried to remove every barrier so that really it's their choice to say yes or no. And it's not because they can look at any systemic barrier that is preventing them from being able to do it. Because what I would submit to you is that there are far more barriers that we can remove than worrying about a hurdle of engagement. And I think if you build it, they will come. And if you make it easy, the more people engage, the better experiences they have. And the more likely that news is gonna spread like wildfire. I mean, we got social media on our side too. You do something bad, it's all over everywhere. Everybody's gonna hear it. But people are also sharing good news. So I try not to focus on those things that I don't have control over. I can't control a person's desire to engage. But what I can do is I can hang a big open neon sign on the door, and I can have the door wide open, and I can make it really nice and inviting, and I can greet them warmly when they walk in the door. That's all you can do. So I would say don't be discouraged by lack of engagement, because I think engagement issues take care of themselves when we work to remove as many barriers as we can. Dr. Richardson.
Dr. Owens. I will say that trust is a huge component. I'm in the Mississippi Delta, been there for 17 years now, and you have to involve the primary provider. You have to involve the primary OBGYN or the primary physician and have them sign off on it. I send majority of my OB patients to UMC for maternal fetal medicine, and they will not move until they come back and say, this is what they told me to do, Dr. Richardson, what do you think? So they trust the people that they see every day. If you, regardless of the grants or the new programs that you have, even if they enroll, until they get that primary doctor that they have a great relationship with, that they trust, to say, yes, please do it. Yes, please sign up. Yes, please go. Then they're not going to do it. So you have to involve the primary provider.
Okay. I love that, and I also think what you said about trust, it's relationship building, right? And so you can build relationships in a variety of ways. And there are some people who might have mistrust from, say, for example, a medical provider, but they trust their community health worker. And so there are trained community health workers who can encourage I use names, Miss Jones. Miss Jones, please go. Well, I don't like those people down there, blah, blah, blah. They're not gonna do anything, blah, blah. And community person who goes to church with Miss Jones or who lives down the street with her says, now look, you know that you got blood pressure problems. Come on, Miss Jones, and I'm gonna go with you, or you need to, and that person can actually be a go-between or a facilitator. I think that what we need to do, though, is really stop believing that medicine is coming from the top down, and we need to really spread it out between a lot of different people. We need more people in our sandbox, more partners, more collaborators, and those things may not come in the traditional ways. It may not necessarily be in the form of a physician or a nurse. It could be a community health worker. It could be a non-clinical person who they trust, who can be the person that helps to usher them in and to give them the confidence. And when they give us a choice, and when they give us the chance, we can't blow it. Because we don't get a lot of multiple chances when it comes to trust in the medical establishment. And that's just period. I mean, how many times is somebody gonna have to mess up your burger before you stop going there? You're just like, you know, I'm not gonna do it anymore. It's the same thing. And we've oftentimes been insulated in medicine and not felt like there's any consumerism. But people have choices, and they also have opinions. And people are becoming more vocal and more empowered to tell people what they want, and when they're not getting it or if they don't feel that they're being treated well, then they're not going to keep coming. Yes?
Great talk. I understand the infant mortality and the high, the F grade that we get in Mississippi, but if we compare non-Hispanic white infant mortality to the national average, and we compare the non-Hispanic black infant mortality to the black infant mortality, how do we do?
We're still leading the pack. And so even when I think what I'm hearing is if we stratified even by these different groups and compared them, what do they look like? But what I will say is that the differences, so first of all, we still are higher, but secondly, the differences are quite stark. And the other piece is, if we can do so well in one group, then what's missing between one baby and the next? What are we doing differently, or are there things that we're missing, or other options for intervention that we're not considering that may need to be tailored to a particular group? Like, how else can we address those inequities? Because, I mean, I don't believe there's anybody who gets up and comes to work and believes that they treat people differently. You think you are treating people, you're treating the patients as they come in. So when we have these disparities, then we have to ask ourselves, well, what exactly is it that we're missing? That when we have two babies that are born in the same place and they are otherwise the same, from the same place, and they live in the same area, why is one outcome different than the other? And I think that's the hard work, right? It's looking deeper and trying to find the answers to those questions. And it's never really an easy answer. But yeah, we still are higher across the board.
Great, thanks, Michelle, thank you so much. I want to invite now two of my bosses, two of the 11 of my bosses, Dr. Lampton and Dr. Cheney, to join me. Before I speak, I would like y'all to hear comments. Dr. Lampton, as I told you, is chair of the Board of Health. Dr. Cheney is vice chair, but Dr. Cheney also does chair the board's subcommittee on maternal infant health. And he and I have been working through these last 18 months as we have been moving towards where we are today. I'd like both of them to give comments in terms of your perspective as the Board of Health regarding this work.
Well, this work has been a priority in the Board of Health for a long time. And this is a historic day that we're here today. It's an important and historic day, and you're part of it. When I look around the room, I really see Mississippi's medical superstars, physicians and other medical leadership. These are the people, this room can make a difference in this state. When Dr. Edney took over as state health officer, his mantra has been that change can't wait. And I think that this really embodies the change that we need to make in the state. And I do want to thank Dr. Cheney, who has led our subcommittee on maternal and infant mortality and morbidity. And his subcommittee has done extensive work, and the recommendation for an obstetric system of care came from that committee. And I do appreciate his leadership on the board, and also Dr. Waits' leadership on the board as pushing forth important things for the betterment of Mississippi. But your presence here is not only important, but critical for change in our state.
I'd like to say that when we made the recommendation to proceed with this system of care, that we envisioned this. No, we didn't envision this. This was it was more a move of on faith and faith in the recommendation of people that we really trust. And I think this is it's very exciting. I do think that we have to look back and see why other efforts have not moved the needle or had an impact. But we also have to look to the future and know that this is not there are no quick fixes. We're going to have to have a long-term perspective. But very exciting.
All right, so now it is my job to show you where we think the obstetrical system of care will satisfy some of the many complexities that are contributing to the problem. And I am gonna hit some highlights from the two previous speakers, but from a public health perspective, from a population level, this is how we perceive things. And John, to your question, please understand that this is only one piece of the puzzle, looking at a very discrete amount of time from labor delivery onset to really the first 30 days of the infant's life, if the baby survives. And that the system of care is designed to look at the deaths that are occurring in that window and looking at our system to see how we can improve that. I was asked recently, as I was speaking with Dr. Carlton at your national symposium, the ER doctors were interested in maternal infant death. How many births do you think occur in ERs around the state in non-birthing hospitals? Not showing up in the ER as far as general and delivering in the ER, but delivering at the shoulder jail. In Philadelphia, it's about 35 a year. And I think, and when I talk to ER doctors, Dr. Carlton, and I'm going around and visiting, and I'm going into ERs, and I'll ask them, what's the thing you worry about the most? And they all, to a person, say, mom showing up, delivering. And many times with very little, if any, prenatal care. But the way I like to introduce this concept is we all know, and you know this, my hospital colleagues, y'all spend a lot of time looking at systems and processes. And you know that the systems that we have in place are perfectly designed to do what? Give us what we're getting. Now, I'm going to work to convince you today that we're looking at a system problem. And Dr. Henderson alluded to that. But in defining the problem, you've heard that we lead the nation in infant mortality. You see, I'm going to show you, statistical data back from 1950 in just a little bit, but you see it's flattened out. And so we're reaching a point, I think both with maternal and infant death, where the things that can occur organically with improved medical care have occurred. And now we're kind of plateauing out, but we're plateauing out too high, so what do we do next to get the next improvements? We score very low with maternal mortality, but not last. And I like to remind people, because when I'm called by the media, they assume that we're 50th in maternal mortality. We're not, we're about 44th, but we are 50th with the babies. We have severe health disparities that remain related to infant and maternal mortality, which goes to your point regarding the difference in mortality rates between Caucasian and African American women and Caucasian and African American babies. And even we are making improvement in the white population of moms and babies. We've made a little improvement in closing the gap with our black moms and babies, but the disparity is severe. With women, it is 3x, and with babies, it's a little over 2x. And when I present this around to lay groups around Mississippi, I have the pleasure and the privilege of being invited to speak to groups of all types. And when I present this information, everyone is shocked. And afterwards, Dr. Eddie, what can we do? What do we need to do? Because Mississippians do not want this. It impacts the Medicaid population disproportionately. More than 80% of the deaths are Medicaid moms, a high percentage of the babies. And I'm quick to say this is not a Medicaid problem. But Medicaid is flagging a very vulnerable population that's at higher risk of morbidity and mortality for the moms and babies. And so we need to make our investments where the biggest part of the problem is. But the beauty of the obstetrical system of care is it's going to benefit everyone, but it will target some of the moms and babies that are not, where the system is not serving well. I firmly believe Medicaid is serving them well, and we've got to close the other gaps. I'm really excited to see, Cindy, what comes out of y'all's transformational maternal health program. I think that is going to address a lot of the problems further upstream. Because when, at Dr. Crofton's conference, I was asked, after presenting OB system of care, well, Dr. Eddie, what's the one thing you would do? That's, well, we've got to improve prenatal engagement. We've got to invest in women, as early as we can, as long as we can, and then also in the postpartum period. An OB system of care is not going to do that. I think Medicaid's transformation program can and will, and we are excited to do anything we can to help with that. And then you heard 80% of these deaths are preventable. And as folks in healthcare, we know that we cannot accept that. Let me ask. I became your state health officer in August of 2022, and I had told Board of Health, as Dr. Lampson said, if you hire me coming out of the pandemic, we're going to focus on maternal infant mortality, and then as that gets better, then we're already starting to focus also on high impact morbidity, because we're not talking about the women who almost died, that survived. We're just talking about the women and babies who died. But I told them that we have to fully engage this problem because it's not going away. And I've been a physician in Mississippi for 35 years, and this has been a problem the whole time that I've been a physician. But why in the world does 63-year-old white internists care about maternal infant mortality? It's because I'm a physician of this state, and this is embarrassing and unacceptable. But more importantly, I'm a father and now a grandfather of 5, and since I've been state health officer, I've had 3 grandbabies born. I sweated them all out because I've learned way too much. But the last, I'll be the first to say, the last baby I delivered was 1988, full disclosure, okay? So I have had to get up to speed very quickly, but my viewpoint is at the population level for the 2.9 million Mississippians that we have. So the point here to make that hadn't been made, that was made in Dr. Owen's slides, but it's important to know that the majority of the preventable maternal deaths were cardiovascular. And Michelle, help me, preeclampsia falls in that group? Okay, I thought so. So, and preeclampsia drives this bus in a very big way. And that I want you to see how our perspective is. We issue the reports every year, and we show the data for the year under study, but then always look at the cumulative data, because these are small numbers. They're small, but they're tragic, and they're high impact deaths, but they're small numbers. We're talking about 40 or so women a year, and then of the babies, Randy, infant death is?
Infants like 319.
319. So the baby problem number-wise is much bigger. And when you're talking about eliminating 40 or so deaths per year, it's that's hard. It's hard statistically. But when you look at the data, we go back to 2017 at the beginning of the maternal mortality review committee work, and then I'll look at that cumulative data and also look at decade over decade so that you have enough that you can study. I wanted to point out here, so Kent, and who all here is from the coast? Okay, well done. Kudos to the Gulf Coast. You are, in 2023, you had the lowest rate of maternal death in the state. When you look at cumulative 2019 to 2023 provisional, meaning it's not gone through the MMRC process, you see Northeast Mississippi does the best, followed by the Gulf Coast. And I want to quickly say, Iris and Dr. Richardson, my friends from the Delta, y'all know I'm from the Delta. I grew up in Greenville, lived and practiced in Vicksburg, and yes, Vicksburg is the Delta. It's just the end of it. But I took care of the whole South Delta as an internist. You know, this is not a problem of Delta Healthcare. This is a very complex, multifactorial problem that impacts the Delta more than any region. And our friends in the Delta who are providing health care are doing yeoman's work and saving many lives. When I was studying all-cause mortality in Mississippi, I showed this to the Board of Health. It was very alarming that as a population, our mortality rate has been going up, y'all. Mississippians have been dying at an escalating rate, and the disparity between us and the rest of the country has been separating, and it's extremely worrisome that our mortality rate going up and getting worse compared to the rest of the country, leading to severe excess mortality. And I immediately said, pull the data for the babies. And here's the babies going back to 1950. And you can see what Dr. Henderson said, we have made progress. Now, this is year over year since 1950. And I want to point out, it's a crazy point, we won't do it, but if you look to around, you see where the slope really goes down, around in the mid to late 1960s and keeps coming down. So Dr. Henderson, what occurred in the late 1960s that reduced infant death? Vaccines. All right, so beautiful picture, the impact of vaccinations on the population of infants in Mississippi, reducing their mortality rate. You see the slope going down with improved trends of infant care, advancements in neonatology, access to more NICUs around the state. All those things have shown a nice decline in infant death. The pink dots are Mississippi babies, the green dots are US average, but you see the pink dots never come down to the green dots. Now they get closer, and then here at the end, these last 10 years, as Dr. Henderson showed, it's leveled out. So that tells me that this is not going to fix itself. And until we see those pink dots get below the green dots, meaning we're doing better than the rest of the country. And y'all, why can't we do better than the rest of the country? We do better than the rest of the country, and I think we do better than the rest of the country in TB control. Education statistics are improving. And if we were running 33rd in maternal death and infant death like we're running in education, we would not be here today. But a concern, when you look decade over decade in this lower slide, mortality rate at 38 per thousand in the 50s and 60s, and you see it's a steady drop, but now we're kind of leveling out where we are. So either we just kind of let it ride, let the system keep producing what it's giving us, or we do it differently. When we look at the infant deaths around the state, Dr. Henderson had showed this slide, but once again, I just want you to see the regions of the state and how they're doing. Again, the Gulf Coast, in 2013 through 2022 cumulative, the Gulf Coast did the best. And I was real proud, Northeast Mississippi, and then the Southwest Mississippi doing really better than I was expecting to see. But then we see the challenges in the Mississippi Delta with very high mortality rates. And then please notice Eastern Mississippi. Not a lot of talk there, but the data is very clear. Our problems, the Pine Belt is higher than it needs to be. And so one thing the system of care will do that you heard from Dr. Waits is we're able to see the high performers and then study what's working in those high performers and then help all hospitals, which will be in the system, to learn and do performance improvement to move their numbers so that there's no reason why we cannot improve maternal infant mortality in the Delta. I wanted to show this. Dr. Anderson talked about drive times, but I wanted to wait to talk today. This study is looking at the closest birthing hospital. Now, if you're in Myersville, Mississippi, Nisqually County, the closest hospital is Sharkey, Sequina, and Rolling Fork. That's not a birthing hospital. They deliver babies. They just don't want to. But now they're a rural emergency hospital. They're not even a full hospital anymore. The closest hospital is either going to be ours hospital in Greenville or our hospital in Vicksburg. And that's a hike in it. To get from Nisqually County to Greenville or Vicksburg is a very long drive. And then if this is a preterm low birth weight, they're not going to be able to stay in Vicksburg. They got to get to Jackson. And there's another hour to go. So this is like the best case scenario. When you look at the capabilities of birthing hospitals based on designations, then these numbers get worse. If you look at going to the best hospital for that challenge, these numbers get worse. And the way our systems of care work, they're not designed to get you to the closest hospital, like Dr. Waits necessarily, is to get you to the correct hospital that can provide the level of care that you need for the trauma that you have. I mean, if I'm driving home today and I have a wreck, well, it means my Tesla wasn't working right. But if I have a head injury, I don't want to go to Vicksburg, although I have a great hospital in Vicksburg. But don't take me to Vicksburg with a neurologic injury. We don't have a neurologist, much less a neurosurgeon. Get me back, to Jackson. However, the systems are designed to do that. Don't take STEMIs to the closest hospital, but get them to the closest cath lab that can do intervention. Now, I know that makes sense to all of us. And the OB system of care is that same concept of getting women and their babies to the right hospital as quickly as possible in the right way. And there are a lot of factors in that. We all understand babies come when they're going to come. And a lot of babies have to be delivered at a lower level of care, but not all of them. And one thing we do see at a population level, we do see high-risk moms and their babies delivering at a lower level of care and then having to transfer rather than get her and the baby to where all the services, as Dr. Anderson said, the ICU and a NICU, get them there and then deliver, and we'll see better outcomes. So the problem is not physicians. The problem is not nurses. The problem is not our hospitals. The problem is not EMS quality, but EMS, Dr. Carlton and I spent a lot of time with EMS issues. Teresa Wyndham, raise your hand, Teresa. Teresa's done a great job helping me today. Teresa is over our EMS Bureau and also has the pleasure of doing system of care work. It's not quality, but our system in EMS is not working. And that impedes and impairs transfers. And when we look at EMS capacity and availability, especially when we're talking about NICU transports, EMS is a challenge. So it is not a healthcare quality issue in Mississippi. It is not a Medicaid issue in Mississippi. Well, what is it? We've been talking on several things, rural travel times. We've pointed that out to you. Less than adequate prenatal care has been discussed, and MMRC looks at the deaths and when they engage in prenatal care, and we see way too many women who are dying are presenting for prenatal care in the third trimester or at delivery. The lack of transparency with our current birthing program. What we do in terms of hospital designations now is called the Locate program with the CDC, and that's where hospitals will receive a survey, and it asks all the different capacity issues for your hospital in terms of labor and delivery, if you have 24/7 OBs and anesthesia or not, all those questions. And that's self-attestation, and our hospitals do a good job of reporting back, but the CDC audits show that there's a 40% error rate in that self-attestation. And it's always towards the hospital reporting able to do more than they really can. And so right now, I would have to tell you that we don't know, except with, there are some exceptions that, we know our baby-friendly hospitals, they've gone through intense surveys, but many of our birthing hospitals, we don't know really what they're able to do, and then it gets even more confusing with NICUs. And is something really, a NICU, and what level NICU, or is it a nursery? And if it is a nursery, what level? And we just have not had visibility in those things. The EMS difficulties, workforce issues y'all have mentioned, and the OB system of care will impact EMS issues. It's not going to impact workforce issues, but just sidebar, I'm a strong advocate for obstetrical-led delivery teams, our OB specialists leading our teams, but using workforce augmentation as they need to, and expand our workforce, especially in the rural areas where we don't have enough OBs, period, but the ones we have are maldistributed, and we have large gaps, as y'all know. NICU availability continues to be a problem. So, we have regions of the state that don't have a significant level of NICU, and that makes it more difficult to transfer babies who are needing NICU support. And we don't have a regional perinatal system, and that has been a consistent recommendation of the MMRC. And perinatal regionalization is where we have it in certain parts of the state where there's organic transfer within the region. Their relationships and transfer systems are built out on their own. But then we have regions of the state that don't have the infrastructure to take care of really sick babies, so they have to transfer out of the region, and we don't have a system to facilitate that. And our current transfer system, as been mentioned, is less than adequate. And that's not just, for my hospital folks, that's not just for moms and babies, is it? That's just, the number one complaint I hear relates from hospital leadership relates to the problems transferring from one hospital to another. But it's very much true with moms and babies. So for me, it's the system. Because what we have with a system such as it is just what has historically developed organically to what we have. There's not been any guiding force like we have with trauma, STEMI, and stroke. And before the trauma system, you just got loaded and you were taken to the closest hospital, and then they would go from there. Now the trauma system with the alpha traumas, the trauma system is there to facilitate. Same thing with STEMI and stroke systems of care, and that's what we're imagining with the OB system of care, not to interfere with what you are already doing that's working, but facilitating where there's a breakdown. And for the system to be able to step in and facilitate transfers. When I have OBs in the Delta telling me, and they have, that they have extremely high-risk moms that they're trying to transfer and they can't transfer them. And they know they need to transfer, they want to transfer, and they have difficulty. And they don't have 4 or 5, 6 hours, 8 hours to make a transfer happen. And delivering very high-risk moms and babies in levels that they're not comfortable with. That's what the system should help, is instead of hospitals trying to deal we are the entity that regulates hospitals and regulates EMS. We don't regulate doctors, but we do regulate hospitals and EMS. And the systems of care are designed to overcome those pain points and facilitate transfer of these folks where they need to get. And then it allows us to study what's going on. It's going to give us a lot of data that currently we just don't have as the system is working. So these are the boxes that get checked. This is high level, broad strokes, and a couple of things are done deals, but most of it is dependent on what our partnership together with the coalition decides what is best for Mississippi and how we need to build it, using the expertise of the Healthcare Alliance with our long history of working with them with systems of care and working together to build that out. And I'm following the roadmap that the Alliance has successfully used for STEMI and stroke, and that's why you were invited today. First step, let's get our champions together. Let's see who wants to engage in making this work. Get our work groups together, get folks to volunteer, get leadership in place. I don't want this to be a health department thing. I want this to be a healthcare initiative for Mississippi, all of us together. But it does achieve perinatal regionalization, which is a national standard from ACOG. Michelle, how long have y'all been asking for perinatal regionalization? Here it is. This will achieve perinatal regionalization. And I'm going to tell you, there's a lot of interest at the governor's office and the Capitol about regionalization. So, and that basically is supporting regions to have what they need within the region to take care of their people, and and stop all this transfer to Galveston and Pensacola, Birmingham when it's not necessary. Maternal and neonatal levels of care designation. It will be the same as trauma, STEMI, and stroke. It will be survey-based, and with us working with hospitals where there are things that aren't in place. If you're wanting to be a level 2 and you're scoring out of a level 3, well, we have corrective action to work with you to get you to level 2 if that's what you want. And then we together will decide. Now, ACOG has standards, Joint Commission has standards, and I suspect that probably 5 years from now, these things are going to be imposed by Joint Commission. But today we have the chance to do it ourselves, and also to do it without statute. That's huge. It will achieve facilitated expedited transfers to appropriate levels of care as soon as possible, whether it's prenatal or postpartum. Whether it's moving the mom while she's in labor, if we're able to, so she delivers, or if it's too late, having things ready to go that as soon as she and the baby are stable, postpartum, we're able to move, and we're not spending 8 hours making a transfer happen after delivery. As it matures, I envision us using the Stork initiative, Marty, as Stork, and I'm really impressed that that's an initiative of training first responders, especially paramedics and obstetrical emergencies in the field. I'm using simulation, it's really impressive. But we have a good ways to go, but what I really envision is our historic death in Humphreys County that I get called about all the time, young mom who bled to death on the side of the road, trying to get to care. What I envision is she dials 911 and we get to her immediately, and now with EMS working towards giving blood on the ambulance, which we have started fairly recently. I mean, being able to transfuse en route is huge. It eliminates the need to stop at a critical access hospital. I mean, you're giving blood, get to the right level of care directly. And being able to do that on the ambulance would be a big deal. But activating the system with 911, that won't be in the beginning, but it's part of our maturation concept. the opportunity to incorporate our AIM Safety Initiative work. Dr. Wilson, raise your hand, please, and her team, Krista, raise your hand, Women's Health, they, the Maternal Infant Bureau has been working really hard. Our baby-friendly hospitals already do this, but right now, AIM safety bundles are voluntary. The data, the evidence is pretty clear. This improves outcomes. And so for you to be a higher level birthing hospital, you're gonna have to be moving towards being a baby-friendly hospital with AIM safety bundles being adopted. Performance improvement data is huge, as Dr. Waits was saying. That's where we make things better. That's where we're measuring the things we need to manage, like Dr. Owen said. Being able to, and the measure, the things we need to measure don't need to come from us at the Department of Health. They need to come from the coalition. The subject matter experts need to be saying we need to be measuring these things. And then as we're able to measure performance, then we can work to improve that performance. And then the Pulsera system that Dr. Waits alluded to, I think is a game changer. The ability, and it's going to be a game changer for all our systems of care. And this is not a financial burden to the hospitals. It's being provided to the hospitals, but we have a baby being born in the ER of a non-birthing hospital that needs to move, and if the ER doctor says, then the system is activated, Pulsera wristband is put on the mama, and the system needs to go to work, and then we're measuring in real time what's going on with her transfer. We're able to see her being loaded, timestamp being loaded onto the ambulance, timestamp when she arrives to the transfer hospital, timestamp if she's going to labor and delivery, or if she's already delivered, timestamp on that baby getting into the NICU. And right now, we just don't know very well, but with Pulsera, we'll be able to monitor all of that. And then it does get to some of the issue with medical record transfers, because that electronic data goes with the mom. So when she shows up at Forest General, she should have her imaging with her, should have her medical records that were available, and just make it easier for everybody. So that will help us with that performance improvement. So game plan, preliminary work has been done. We've been doing that since 2022, and we've had endorsement by the Board of Health to proceed. I've been working with many of you in the room to get buy-in. I'm really grateful that UMC came on board pretty quickly, very grateful our hospital leadership came on board really quickly, and as I have been, and I was really grateful that today, every time we were inviting somebody, they would want to bring 2 people with them. Or I can't go, but can so-and-so go in my place? And absolutely. Partnership with the Healthcare Alliance, we've already submitted and moving forward together. And coalition building, culminating with today. So I'm hoping that we will all be part of the coalition. You don't have to be, but we are inviting you to come to the table to help us build the system together. We need to go forward developing work groups, and the Alliance will help us in that leadership of what are the general work groups we need, and then we will be listening to experts in the field in terms of work groups. We definitely need performance improvement. We need maternal levels of care group, neonatal levels of care group, EMS work group. There will be at least 4 or 5 work groups that are needed. Phased-in implementation, it's difficult you can't just flip a switch and go live, but hearing from my colleagues in the Delta, we want to make sure we're providing support in the Delta region as quickly as we can in a way that's helpful to them, and then go from there. I expect maturation is going to be occurring over the next 3 to 5 years, which would include the Stork Initiative and EMS, activating at 911. That will take time, But maternal levels and neonatal levels of care can happen pretty quickly. Building out the core of the system, much of that's been done. We can get that done fairly quickly. There's a lot of regulatory work that has to be done by us. We'll get that done. So really what I'm hoping is between now and the end of the year that we'll have work groups established, leadership in place, and then advice coming out of those work groups to those of us who are having to drive the bus between the health department and the Alliance. So that is the concept of our fourth system of care in a nutshell. I'm happy to take any questions or hear any of your thoughts. Let me say it's not going to cost y'all anything. So there will be no financial burden imposed on hospitals or any of healthcare. The Department of Health is shouldering the financial burden. It is significant, but I think this is a great opportunity for us to impact, and I would say, Randy, most likely will make a stronger impact on babies, where we have the largest numbers. I think being able to get our babies into the NICUs faster is probably going to be our highest impact. But y'all, we don't have to help very many women survive their pregnancy to move that needle. And I am optimistic that the OB system of care will impact a high-risk area that put women make women very vulnerable and provide some safety net there for them. So, Michelle, if we're reducing our numbers 5, 6, 7 a year, fewer deaths with moms, maybe that's gonna move the needle. And we won't be satisfied with that, but you may have heard me say my goal is not to get us off the bottom, it is to get us off the radar. Where I want people calling me not to talk about us being so low in maternal infant death, but calling me to say, how'd y'all do it? And it's, I would say, and we did it, meaning we as Mississippians did it by thinking outside the box and being innovative. We are not the first state to do this. There aren't a whole lot, but I've been working closely with my colleagues in Texas. They have a system of care much like this. Ours would be a bit more robust than theirs, but they're I would say probably 5 or 6 states that are ahead of us in this, moving in this direction. As we build this system out with a historical experience that we already have building systems, I think this will leapfrog us to the front. And it will demonstrate to the nation that Mississippi has a powerful initiative to reduce mortality. And as it matures, we'll be moving from talking about mortality to morbidity, to improving morbidity, as we keep improving this. So let me stop there and see what thoughts or questions you have. Mr. Carlton.
I really like those last few slides that you had up, Dan. One point to make, and I think it's kind of implied in some of what you were talking about, but by the time you end up in a non-birthing hospital or utilizing EMS, there's already been a system failure.
That's right.
And we need to understand that and try to have as much as we can possibly do done prior to that. I've delivered my share of babies in birthing hospitals in the emergency department. So it can happen even in that setting, but at least you've got more resources to deal with the problem when it occurs. But better prenatal care, a lot of things that go along with trying to prevent this downstream sort of effect that we deal with. And we did this, when we stood up a trauma system in the state, we sort of did, and I think it's most analogous to what we're doing here. There was a lot of education that was done regarding car seats for infants to prevent more severe infant injury in MBCs, seat belts four-wheeler education, a lot of different things that we did. I see the analogy there with what we're wanting to accomplish here. And I think we need to place as much emphasis on that as we can as we develop this system.
I agree fully, absolutely. Thank you. Martin?
Dan, first of all, thank you for leading this group, and you mentioned that you really didn't want to paraphrase, reinvent the mousetrap, the things that are working well, you didn't want to disrupt those. And this may be a question for Dr. Cheney's subcommittee, but do you envision partnering with centers in Memphis and Birmingham and New Orleans and Mobile to be part of this system?
I do, in the same way that we're dealing with trauma, especially and burn trauma particularly, but also utilizing the resources within the state as much as we can. But if we're up in the northwest corner and this baby needs to go to Memphis, but there are a lot of babies who are going out of state that don't have to go out of state. And a lot of that relates to, well, I can't get them to hospital X, but I can get them to Y outside the state, and they follow the path of least resistance. So the purpose of the system of care would be to reduce the resistance. And also, really importantly, not dumping on anybody. So these are not, all these transfers don't all go to UMC if they don't need to. But one thing we have visibility on the beds. We know who has open beds. And if a baby, is at 32 weeks but needs to move, we know Amory can handle 32 weekers. And if Amory has open beds, Tupelo, high level NICU, Forest General, the Gulf Coast, we're not going to be shipping babies from Greenville to Gulfport unless we just have to. We need, my vision, Iris, is that we'll be transferring them within the region, but we've got to do some investment for that. But some babies will need to go to UMC, some will be able to go to Tupelo, some will be able to go to Hattiesburg. A lot of it's going to depend on where hospitals shake out, where NICUs shake out, but also, we're not getting in the way if you don't need the system. So if somebody has a good relationship transferring to Hattiesburg, and they call Dr. Henderson to transfer, God bless, the system was not activated, the system was not needed. But if some, I know y'all take care of Waynesboro, and for some reason y'all can't take care of Waynesboro, they can turn on the system, and then we step in to help. Does that make sense? Does that answer your question well enough, Martin?
Yes, thank you.
No, thank you. Iris?
And she was saying the Delta really does need a NICU.
Yes.
Being as large as we are in that area, we had one at one time. I guess before I retire, maybe we can think about trying to establish another one. But I think that's something that we really need to look at.
Absolutely. And I mean, you know me, I've been advocating at the Capitol about healthcare and the Delta, hospitals in general, but Delta hospitals particularly, especially, the scary times in 2022. And I keep preaching we need a NICU in the Delta. And you know what I'm hearing? We're interested. And they're interested in funding it, but they want to see the data. And, so they're pivoting to us, and our data is sketchy. We'll have robust data coming out of the system of care. And we'll be seeing where those transfers are going, where out-migration's happening, and then looking regionally, be able to make recommendations that, this makes sense for the NICU to be here. And then the state is telling me they're interested in investing in things like NICUs, that as long as there's a return on the investment, that they're deliverables. If we're investing in a NICU, that there are deliverables about that. So I think that the system of care helps us in that regard for there to be strategic state-level investment in areas of the state where we definitely need it to reduce these travel times. Yes, ma'am. Anita?
Thank you, obviously, for doing all this. Two comments. When we talk about transfers of OBs and moms from one place to the next, I think two of the things I often hear about are reimbursement And then quality measures, because hospitals are paid, or Blue Cross Blue Shield has their levels of distinction based on C-section rate. So I do think there has to be some acknowledgement of some quality measures that may or may not be impacted, and also reimbursements on, you know, if a OB care has been bundled and paid in one hospital next, and then a transport to the other. So those are, I think, two things that in this system of care we have to think about.
Yeah, I agree. Her comments were, one, quality measures, which is part of the PI work. But again, the quality measures for the system of care need to come from the subject matter experts, you know, and not a government stooge like me, you know, but a subject matter expert. Our neonatologists need to give us those quality measures. Obstetricians, pediatricians, family medicine docs need to be helping us with that. So we measure what needs to be measured. And then payment is an issue, because right now the incentive is to deliver and then transfer. We all get it. But the outcome measure, the incentive will be, if able, transfer and then deliver. So those are, and that's why I'm grateful our partners at Medicaid are here to listen to this. And I mean, the system of care is not going to be dealing with that up front. And we don't have, you know, but I've even been pitching the idea of a birthing fund, like the trauma fund. Although all these deliveries are covered, but we have the problem of, you know, if someone transfers, they may have done a fair amount of work that they're not going to be compensated for. And, you know, to have a birthing fund to incentivize transferring to get the best outcome. And, you know, that's why, Cindy, we definitely want Medicaid at the table to get input of what's doable, what's not doable, in terms of incentivizing the deliveries to occur where they need to occur. But I think we will also have the data as we see deliveries occurring or where they should, or babies getting to NICUs faster. I mean, we should see outcome improvements for those NICU babies, and I would anticipate shorter lengths of stay in a NICU and have some cost savings there. Anybody?
One more.
Okay.
Oh, sorry.
Go ahead, Anita.
So in addition to when you're teaching stork, I do think stable is also important for those NICU babies, just teaching that sugar, temperature, airway, breathing. As you mentioned, in these ERs.
That's why I need you to volunteer for
babies.
work.
But I do think, as you mentioned, you know, those babies are getting delivered in some of those hospitals. So having the ER nurses and the ER staff know how to stabilize those babies in addition to take care of those moms.
Absolutely. Thank you. Dr. Waits.
I was going to point out, and I didn't in my talk, and it's applicable to what you were talking about there. In STEMI, it's worked that we don't have any diversion. You can't divert a STEMI patient. You know, some hospitals say, well, we're totally full. Put them in the hallway, get them to the cath lab. So I think it would work equally well with an OB system, but that is something to consider.
Yes.
And the other thing I would say is, talking about those quarterly reports that on quarterly meetings we have, those are both STEMI and stroke together. So we would just add this within the Healthcare Alliance to be the third group to be on the quarterly meetings.
That's right. And for the hospitals, I know that, y'all know that we've been building the system of care for sepsis. And as we've been talking to hospital leadership, you know, we're going to continue building that system, but hold its implementation back as we focus on the OB system, so we're not hitting you with two systems. You know, we're switching out. We see the priority at this point being the moms and babies, get the OB system in place, and then complete out, keep doing the sepsis work and be ready to implement at the right time, where we all agree that the hospitals are, I think it's ready. Let me get this one ready. Yes, ma'am.
You touched on it a little bit, but I do believe there's an opportunity to do a lot more education with the level 4s, with the level 2s and level 3 NICUs. I see that that's a need in my area. and we need to see how we can cut out the red tape so we can get that education to the level 2 NICUs and the level 3 NICUs, because they may not have the volume of the level 4. So we need to figure that out for those rural areas to help that.
Absolutely. And y'all are killing me. One system, 1 is at the bottom and 4 is at the top, and the next one, 1 is at the top and 4 is at the top. But yes.
But that's the true need in our area.
Great.
And ask for it, so that's something that we want to be part of.
Outstanding. Thank you. So you're signing up.
Yes.
All right. Thank you. Who? Yeah, right.
I'm very grateful to the folks from UMC that came today, Dr. Jones, Dr. Fenweedy, Dr. Tucker. And I know y'all spend a lot of time thinking about things like this as well, because you have plans for the state too. I was just wondering if you could comment on some of the things you're thinking about for our maternal system, perinatal system.
Well, I just want to name you nephrologist in chief newborn medicine. Thank you so much for the opportunity to be here. Dr. Tucker and I work together. We deal with this all the time, and we worked with Michelle in the past. And we're very close with our partners across the state. So this is a very welcome development. We are the only level 4 in the state, but as Dr. Edney said, we don't want to be bursting out the seams. If there's a 32-weeker or a 28-weeker that can stay in Forest General and be taken care of, Dr. Henderson knows we're there when he needs us, and we will always be there. So all the things you've said on the board, we've lived through it all. And we know now is the time. We have people doing studies within the division, doing research. We're part of huge neonatal networks across the country. So all the data you've shown, it is real. I see it every day. I live it every day. So we're ready. Count us in. Our boss, Dr. Jones, is here, and they've been supporting us. We have partners up in Tupelo. We work with the NICU there. We have partners in Greenville. We're working on something there. It's started off nice, and we are looking towards progress in that region. We used to be very close with the coast. We're still friends with the coast, but there's still some work to be done there. So yes, we want regionalization. We want babies to stay in their region. We want the best outcomes. One story I'll tell, I got a call from Port Gibson. I was on call. It was a 23-weeker that had just been delivered. And the nurse practitioner was freaking out and was asking what to do. And I said, what's the baby's temperature? Who can guess? It was 88 degrees. Yes. So normal should be around 97.5. So I said, get saran wrap. And he said, where will I get that? I said, in the kitchen. Go to the kitchen, get the saran wrap, and wrap this baby up now. The baby survived, went home. Obviously, neurodevelopmental outcomes are not the best, but that's what we want to stop. We want them to get the best start so that they deliver in a place where they are ready for them. And if they need to be transferred, we're ready to take care of them. And when the moms come, and they get transferred to Dr. Tucker because they cannot stay in the lower level of care, we're there that, you've seen pictures of us going for the delivery of the quintuplets. That's what gets us going. So we're fully supportive of this. Yes, sir.
I got a couple of questions for you, if I could. One of the biggest problems with inter-hospital transfers, and it was kind of alluded to by Dr. Weeds, is capacity. Is there a capacity issue with the NICU at UMC right now?
I don't have a capacity issue ever.
Okay.
Because I have Tupelo. If I can't get you to Jackson, you could be in Tupelo, you could be in Greenville. I have friends in Hattiesburg, they could be there. And there are multiple hospitals within. So essentially, amongst us neonatologists, we're kind of doing that, even though it's not formal. So nobody ever gets diverted out of the state because I have friends I can easily call and work with to do what needs.
So you kind of got your own regionalization system, it sounds like.
We
The
kind
other
of.
The other thing, this kind of a follow-on to that is with, if, once this system is fully implemented and mature, I would certainly hope that there would be less of an issue with capacity in any of the places, because there would be less need, fewer premature births, fewer difficult cases for you to have to manage in the NICU. Do you see that as a possibility?
The rates have been steady, so I'm not sure that will go down. And with the advances in neonatal medicine, I'm now keeping babies that are 22 weeks.
Yeah.
And a 22-weeker to get to 40 weeks, it takes time. And there are morbidities that result from the things I do, putting them on the vent, sepsis, and things like that. So I cannot 100% say that that will change. And I don't want to say it will be worse, because I just came back from the Pediatric Academic Society's meeting, and we're now talking about 21 weeks. So I cannot promise that.
So to answer
Why not continue?
Dr. Henderson's question, there are two big thoughts that come to mind. First of all, how's this going to affect the grassroots OBGYNs, nurse midwives, and the folks who are on the front line? I was uplifted when I walked in today. I told Dr. Waddell I'm glad to see some real doctors here today, because this is the one, that's who this is going to affect primarily. So I think that's where this focus needs to start. Now, the second part from 30,000-foot view is the what about me, what about us? And the thing that comes to mind for us is capacity. We rarely turn down a purely obstetrical transfer. Now, you may call and we're backed up on labor delivery and women's urgent care, and we have to call you back in 4 hours or 6 hours. To your point, sometimes that transfer can't take place immediately. But we do turn away a fair amount of transports for moms who have to go to an ICU, and we just don't have ICU beds. So, how this will affect us as far as capacity going forward, that is a thought or concern that I have. But Dr. Jones, I don't know if you had anything to add to that.
Yeah, well, first of all, thank you, Dr. Edney, for getting everybody together and for everybody's engagement in this. From the standpoint of a few things that go through my mind, obviously I'm not the content expert, Dr. Pham, Dr. Tucker, but when I think through this, one of the most important components of the holistic approach to this is how do we get the right patient in the right place at the right time.
Right.
And that doesn't mean that every patient has to go to Forest General or to UMC.
Right.
It means that we need to educate and give the tools to the people in the community to know when those patients appropriately go somewhere and when they appropriately stay. Those tools, I think, have to include education like STORC and other components that have been talked about. Telehealth is a huge component of that. Being able to monitor these mothers during their pregnancy to understand when they're getting in trouble, helping the community OBGYNs have tools to see that early when they're not touching the patients as much as they should because the patients aren't compliant. One of the reasons I wanted Dr. Chandra, who's our Chief Telehealth Officer, to be here because they've done some work, and that work can be, I think, very important, if not transformational, to a system such as this. And then, like Dr. Tucker said, we have to do our part to understand what the needs of the community are, how we at UMC can best fit those needs, and then what resources we need to add. So hospitals are going to have to do some work here too, to know when and what is needed. It's beyond, it's more complicated than just moving a patient around. We have to think about the transport side, the hospital side, the postpartum side. So there's a lot there that goes into it, but we are committed. We want to see this change. We don't want you getting phone calls. We don't want our state out there, being the notoriety we get is the worst infant outcomes in the country. We'd rather flip that narrative and have people say, how did they achieve this? So we're all committed to it, but I think it's gonna be a disciplinary approach to using all the tools available that we have now, that we didn't have when we set up a trauma system of care. There's a lot of tools available now that I think could be helpful.
Absolutely, I agree with all those comments. And whatever is built, it will be what we build together. And that's how the systems have been successful in the past. And I plan to follow the same roadmap with this one. But it's, as I look across the room, I'm extremely optimistic because I know we have the expertise in this state. Now, the assumption from the guys in New York calling me is that we don't. And I quickly disavow them of that thought because I've never had a thought of my grandchildren being born somewhere else. I have full confidence in my obstetrical colleagues and in our hospitals. I don't have confidence in the system, but we can make systems better together. And that's what this is about. It's taking what we have and making it better in a way that works for all of us. All right, so I get an A for the day because I won't get you out of here early. But thank you so much for coming. We at the Department of Health are extremely grateful for your time. Your time is valuable. And what I would ask of you now is if you are ready, then leave behind, make sure Teresa has your correct contact information and what your area of interest is. And then we will be spreading the word because the work groups are not just limited to those who came today. So folks back at your institutions, colleagues, others in your community that would like to help us, to just get us that information, and we will be happy to get them assigned. So, and if you need to, when you get home, you can email us back. But y'all, thank you so much, and please drive safely going